Hi, my name is Jerry Hesch. I am a physical therapist who works part-time in Henderson, Nevada, very close to Las Vegas, Nevada. And today we're going to talk about a technique that I use to treat the symphysis pubis joint and how I treat minor, either acute or chronic cases with symphyseal diastasis, which is a splitting and a separation of that joint. Here's some contact information. And I treat clients with complex sacroiliac joint dysfunction, but I also treat the entire body. I teach courses on it, and here is some additional contact information. In looking at the Pubic Symphysis, it's a very strong fibrocartilaginous joint with hyaline cartilage on the pubic surfaces. This joint moves very minimally and probably doesn't move at all with typical activities of daily living. In the female, in the pregnant female, in response to hormones such as relaxin, which couples with estrogen, enhances mobility of the pelvic joints, being the paired sacroiliac joints, and of the symphysis pubis, so that the pelvis can actually grow in size to accommodate the growing fetus and also to allow ease of movement during delivery. There is a potential space in the middle of the symphysis pubis, and that can fill with water or fill with fluid and swell, and that does create a weak point in the middle of that symphysis. You can read the literature and you'll read that there are different reports of how often this occurs in the population, and you'll get some very disparate recordings of being very minimal to being frequent. I think a fair statement would be to say that a spread, which you could measure of course with x-ray, that you would simply do after delivery, not during the pregnancy, could be compared to an x-ray that was done sometime before pregnancy, and you can compare those widths. I think that it would be a fair statement to say there are many people who have up to an increase of up to 10 millimeters width. And they seem to tolerate that well, and they seem to recover well. When the spread gets on the order of centimeters, beyond a single centimeter, greater length than that, they tend to be symptomatic. What brought me to treating the symphysis pubis back in the 80s was that at that time I was putting together what I call the most common pattern of SI joint dysfunction, and that is according to the Hesch method. And I noted that there were sequential patterns that the pelvis would go through when testing and treating motion asymmetry throughout the pelvis. I came to agree with the literature, especially the osteopathic literature, that states that when the pubic symphysis is dysfunctional, that is primary. That's the first thing that needs to be treated. And I find that dysfunction at the pube correlates beautifully with movement dysfunction of the sacrum. They are both very inextricably linked. I'm not going to elaborate on that connection, but I always treat symphysis pubis first, and then I go on and treat the sacrum. A pattern that I discovered a very long time ago is not described in the traditional body of literature, for the simple fact that the traditional body of literature palpates the top of the pubic bone, palpates each tubercle, and palpates the crest. To that, I suggest you palpate on both sides the middle portion of the pubic bones and the lower portion of the pubic bones, and that you also palpate across the fibrocartilage. A pattern that I found with respect to the entire pelvis is one in which the pelvis orients to the left. So when the client is lying symmetrically, the pelvis is still oriented to the left, and when you palpate it across the symphysis pubis, it's a flat plane. In contrast to that, there is a pattern that truly does involve the symphysis pubis and the SI joint, in which the left pubic bone, much more common than ever on the right, shifts posterior. So I call it a pure posterior glide, and when you palpate from right to left, there's a distinct step off along the entire length. When you do a movement test on that joint, what you find is that you can actually create a little more movement on the left side with respect to posterior glide. When the client is prone, you'll notice the ischium is more posterior, and you'll notice that you cannot create anterior glide using a moderate amount of force, whereas on the other side, you can in fact load that structure and spring it, and the same is true for the right pubic bone. I went back in my box of past workbooks, and the first time that I spoke of treating this using a fulcrum and treating it for a long time, meaning 5 minutes for creep, was in my 1989 workbook. And I taught a workshop for the Women's Health section of the American Physical Therapy Association. I taught that in 1989, and this is that workbook. And in that workbook, I discussed treating that posterior shift, or the outflare pattern of the ilium, by using a firmly rolled towel or a foam roller and placing it underneath those structures for 2 to 5 minutes. So that was the beginning when I started using these fulcrums to create glide. I like to do this treatment for 2 to 5 minutes because it's a very thick structure. The anterior posterior depth of the fibrocartilage is a minimum of 10 millimeters, and of course the height of it is twice that or greater, 2 to 3 times that. It's a very dense, very, very strong structure, and the arcuate ligament beneath it is extremely strong. It also has anterior, superior, and posterior ligaments. So if I want to induce movement in this structure, I'm going to use a very low force because I don't want to provoke pain, in which case the body would then create some muscle guarding and prevent what I'm trying to accomplish. So I use a mild force, and I use it for a very long time, based on basic science, basic physical therapy, basic science of connective tissue. You could pick up any book on orthopedic physical therapy, any orthopedic textbook, and look into the science of connective tissue, look into the science of treating scar tissue. This is a wonderful book, Dynamics of Human Biological Tissues, by Currier Nelson. Wonderful resource. You can read those early chapters and you get the sense that connective tissue indeed has viscoelastic properties, and that it should be treated with a long duration, low force load. I'm going to wrap up this part of this film, and then we'll go on to the second film, and I will discuss diastasis in more detail and how I use foam rolls to create forces to help close that structure. Thank you very much.